Hey guys, Melanie Grant here. Today we're going to talk about the middle process of the revenue cycle management, specifically looking at Chapter 10 with our Principles of Healthcare Reimbursement and Revenue Cycle Management, where we look at resource tracking. This is one of my favorite areas because we're going to talk all about coding and the different roles that medical coders, billers, and managers in the revenue cycle play in the middle part of the process. Well, I'm going to share my screen with you, and we'll use the PowerPoint that goes along with our chapter reading in our class. Now, today we will be using the Principles of Healthcare Reimbursement and Revenue Cycle Management book, which is published by HIT2060 7th edition, and this corresponds with the class for our reimbursement management course here at CDM for Health Information Technologies. And of course, we have a couple of learning objectives, as always. Some of the big areas that we're really going to look at is what's called the charge capture, and really identifying how various coding is applied in the revenue cycle management, looking at the structure and the coding process in terms of finances. How do we get paid? So oftentimes this is referred to as billing. The first thing we talk about is the terminology of charge capture. So this is really just the process of capturing what was done and creating a charge for it. In other words, there's various different code sets. As we've learned in the past, we have our diagnoses, which are captured with diagnostic codes or ICD-10 codes. And then we have procedures and services that are captured with either ICD-10 or CPT and HIT2060. All of these identified as capturing charges or charge capture. We put them together in order to say what services were done, what supplies were given to the patient, and then we code and assign whatever is the appropriate codes for the service that we gave for the facility or for the provider directly. So as you see here, there's a couple of different parts of the coding process. First, identifying if you're billing for facility or your professional setting, and then single path coding, just talking about what part of the coding process you're in. And again, you can kind of see some of those being relayed here. As we talked about in the past, there's different types of services. So depending on where you're at, depends on what you're capturing and what you're listing. Here you can see like what might be included in a hospital setting, where you have room rates, unit charges, and overhead all combined into one chargeable capture. This may include the coding for specific services done, as well as everything that the patient is receiving, like even their food in the hospital. As we're capturing these things, there's a few different ways we do that. So you have these three different methods here. The computerized provider order entry, which is basically where the doctor, nurse, or other qualified staff goes in and looks at your electronic health record to capture what they're doing. This sometimes goes off of just the terminology they're using. So they may order a specific procedure or lab that they're wanting to do. And as they do this, it captures or is associated with the correct coding that would capture or be utilized to show what charges would apply. Barcoding is commonly used for certain types of services, especially in a hospital. So if patients are receiving medications, if they're getting procedures from the nurse or other tech staff, oftentimes they'll have something that can scan a barcode on their wristband. And then, of course, the Charge Description Master or CDM. This is something that is maintained by a lot of backend users in the revenue cycle, which simply means to say people in the back of the house or individuals that work in the administrative portions of the offices that are looking specifically at how the terminology is set into your electronic health record. There's a lot of crosswalking, so you can see here some examples of data table that might be used. This allows us to capture claims, which is your billable charges, all put on a one sheet or electronic form. And it also gives us information about the patient for reporting purposes. So we'll look at a little bit more at that next. So again, it's typically managed by your finance department. Really, a charge description master should be something that is reviewed by a medical coder, someone who understands the specific details in how the classification system they're using or code set they're using is organized and what guidelines apply to it. When looking at the CDM, the person who is in charge of that or the team that's in charge of that will pull together all of the information that is specific to what is done in your office or your facility. And oftentimes they may even put together like a charge master sheet that can be quickly referenced for the provider. On your CDM, a single line can include all of the information that you need. So we actually have an example next, or in the textbook, we can look at those. I'm going to pause the video here and we'll pull up the tables 10.1 and 10.3 and take a look at that together. Okay, so as you can see here, the CDM structure is really identified based off of the computer information that's in your software, your electronic health record. We have a couple of different things here: department codes, charge codes, a charge description, a revenue code, a HIT code. Man, that's a lot of codes. Not to be confused though, the biggest thing that is important here is being able to pull up information from any of the different data areas that are listed into your CDM structure. So whether you're looking up charge codes to pull up information and updates, or you're entering the charge description from the provider or middle process side, all of these are going to be corresponding to each other in pulling up the information. For example, a VIN puncture here, which would pull under Department 200. You can see there's two different types and associated with the same revenue code, but the HIT or CPT code would be different. And both of these are going to pull up the same price. However, the HIT code, the G0001, is inactive, while the CPT code 36415 is active. So you can see here how this would have been updated to include new information as the data was entered into your system. Our table 10.2, so that's table 10.1, and figure 10.3 shows this being put into a claim form. You'll notice in a claim form here, we have the revenue code associated, and we have the description and CPT code, but you don't have all of the information that was pulled from the charge from the CDM. So like the charge code itself was not in there, and the charge amount or the active versus inactive status is not, well, the charge amount is listed, but the active or inactive status is not. Sorry to misspeak there. In table 10.2, we can see an example of how the charge description, or also known as a lay description, can also be pulled from different terminologies. So you see here, for example, an abbreviation of the same terminology associated with your CPT code, and a shorter description, some of these actually being longer than the full charge description. The reason for these examples here is different providers will pull up information based off of your description, and they may have a different description or a lay description that's different from what's actually entered in the initial charge description that's in your system. For those reasons, it's very important that as you are looking at information like your CDM, there's what's called a crosswalk, which takes the information here and walks it over to cross it into various different terminologies that can be used. So as we look at the charge codes, it is important to keep in mind, like, where does this information come from? A lot of it's going to be very specific to the hospital or facility in which you are currently working with. The charge code is something that's given from the system, while as well as department numbers, while the revenue code and your CPT code, as well as the charge description, comes directly from code sets, identifying those particular areas. So how the information is structured? Well, you have a coordinated distribution and a unique information that's all played into this information. So you can see here, like, some of the numerical information goes directly in order and will go in different brackets of information, such as a series of codes that are associated with PT for your ancillary services. Each of these codes, though, will need to be reviewed to determine that information is accurate. Duplicate charges tend to cause problems. So as you're looking through things, if you find the same description associated with a different code, it's very important that your office is looking at how the information is entered into your system to determine that the data elements are accurate, and that anything that is, for example, that mini puncture where it's inactivated, that it's properly taken out of use in your system. So as mentioned, your department number here is going to be specific to your hospital, while the revenue code is something that's specific to the type of service. Your revenues codes come from the National Uniform Billing Committee, or UBC, and it applies to pretty much everywhere. They talk about facilities here, meaning hospitals, but you may hear revenue codes outside of hospitals and facilities as well. Looking at specifically at those revenue codes, so we have some examples here of some of the information that's specific to payers, edits, and how we use revenue codes in reimbursement. So as payers receive revenue codes, they compare them to different areas. So a certain revenue code will be associated with specific payment information. Edits or denials will apply to your codes based off of CPT or HIT codes, revenue codes, and diagnostic code information. So depending on what you're billing and for what purpose and how it's billed in what area, will identify if something is allowed or not. And then as you look at these codes for payment or reimbursement, you can see here like some of the examples of payers who will reimburse based off of specific charges. So you have one payer who pays 60% of revenue codes that have code number 610, while Medicare will be more specific to the code that's used, and here too will reimburse based off of the HIT codes. So if we take a step backwards, you can see the code we were looking at a moment ago. So some payers will use, sorry, not the department, the revenue code here, while others use your HIT codes, your CPT code here. Okay, and we did go forward. So, and again, we have this HCPCS, which is HIT codes, also known as CPT, depending on the number versus alphanumeric number for those of us who are into coding and know a lot about it. Basically, we identify the procedural service that is rendered. Identifying that will also apply based off of who is the insurer. So by now you know that Medicare has a series of codes in the HIT manual that are very specific during that side for that. While Medicaid will also follow a lot of that, they use a combination of both CPT and HIT. Blue Cross Blue Shield also has some very specific codes found in the HIT manual, but not everything is going to be found in the HIT. So you will have a combination between CPT or HIT, depending on where your patient is located at. An example here, obviously calling the CPT 49180, the HIT code is not incorrect because all CPT and HIT are level 1 and level 2 HIT codes. Keeping that in mind, when we get to the charge description, this is going to be something that is very brief and meets the definition as defined by that CPT or HIT code. Usually, in this case, the 49180 is released from the AMA. A code that's found in the HIT manual would be released from CMS, and those would be the specific definitions used by your facility. Coders would then take those full descriptions and break them down to the shortest version of those descriptions as well as more in-depth ones to enter the information in the system. And this basically just kind of says some of the same information. Descriptions need to be shortened to work in the EHR. It should be easy for your clinicians to find and also easy for patients to understand. So what we put here, when we enter this information, this charge description, that is not only the description that's going to be listed when looking at a biopsy, surgical biopsy of a mass, which is what this reads to me as, but that's also what your patients see. That's also what your physician sees. So if you have too many abbreviations that aren't as known, that would be something to consider when identifying exactly how the patient is going to see that on their bill. And then, of course, the final thing being the charge in the system. I think this is really important to point out here in revenue cycle management that where they say the charge is not equal to cost, the charge is what the hospital or facility bills for that service. That includes everything that they feel should be covered, but there is going to be a markup from, just like with any kind of service or business, there is a markup from what it costs us to provide it and what we actually charge for providing it. In general, most facilities and hospitals do about approximately 150% of what Medicare would pay for that charge, or for that service. And so that's how a lot of facilities will determine their charges. But everybody has a unique structure in how they identify what their charge is going to be. The charge status indicator. This is also part of your CDM structure, which tells us if which line you're currently using. It helps us to keep our charge, our CDM separate and preserve history. Identify which line items. So we use the term line items a lot when we talk about what our charges look like. And I'll go back to our example here. So each one of these in this UB form, which is an electronic version of a claim form that used to be sent in by Keeper. Each of these is called a line item. And so there's 2 line items of the 300 revenue charge, for example, one for the venipuncture and one for the metabolic panel. Those are both going to be associated with lab work. And so you can see that here, although the 301s are also associated with lab work. And you can see that by reading through this, you have a magnesium, a troponin, and CPC, and all of these have a corresponding 8000 series code, which pertains to laboratory in the CPT code book. Here, the 320 is an x-ray of the shoulder. And so each of these descriptions is how that would show. Each of these items or line items identifies something specific. Okay, so we'll go back to our PowerPoint here. And so the charge status indicator is just kind of identifying what lines are we on, which ones are we using to identify that information. Now, within the CDM is also a section for modifiers. Modifiers, as you know, are only utilized for CPT or HIT codes, and the definition of a modifier is to simply modify the definition of the charge description itself. So as we look at a code that is associated with the description, if there's specific details that are missing or need to be identified, then we would list those, such as left and right or bilateral services, or in some cases, every single time that we do something specific that requires a modifier like anesthesia, we are always required to say the type of provider that provided the anesthesia or the status of the patient when receiving the anesthesia. So as we know, there's some modifiers that are always listed based off of the type of service, while others are listed based off of the need. The next part of your CDM is your payer identifier. This really is just saying what kind of payment payer that you're billing to, and it's going to identify specific information to your office so that you know, like we said earlier, if it's a Medicare patient, there's certain rules that we will have to follow, whereas non-Medicare patients don't have those same billing rules. Now, as you're building your CDM, a maintenance plan is something that we talk about. Mostly, it's just kind of like, what is the workflow? What is the common plan for how you process your claims? A lot of the terminology in here can sound a little new, but don't let that throw you off of what we're talking. In the middle process here, when we talk about maintenance, we're talking about the process of updates and the process of maintaining the integrity of your documentation, the integrity of your charge master, and what specifically is in that. So you have certain things here like a maintenance department or team, and they have specific projects where they're updating crosswalks. There may be policies and procedures that are followed and updated regularly. And then as they work with hospital departments, talking about maintenance, this is areas where as providers find information that doesn't make sense to them, or if they can't find descriptions, they provide that information, and a maintenance team will review that, or various other teams that work with them. Under that, so you can have, for example, the clinicians have services or specific details that they need, and then the staff who maintains the CDM will review for compliance and billing information, and make sure that everybody is on board. So as you update various areas of your CDM for your charge capture, it's important to include all of those things. And if you're in the department that would be working on that, that would be part of the protocol that you would follow of how do we change these, what do we change it to, why do we need to change it. Okay. So developing that is part of creating a maintenance plan. Again, that term mapping out or crosswalking. So when we map out something, we're identifying all the different areas from A, B, C, and making sure they match up with X, Y, and Z. Identifying any changes in codes, modifiers, and making sure that those are commonly updated regularly. This is something that's ongoing, of course, and depending on if you're in an outpatient setting, it's either yearly or quarterly for outpatients. So there will be different information from the payers as to when different charges are updated. And to talk about what that looks like. So your CPT updates, your HIT updates, and the PPF updates each have unique schedules on when they're available. So even though some of these may be yearly, some of these will have specific schedules as well. And that's important as a maintenance purpose to be aware of when those updates are effective. Oftentimes, you'll be able to see those updates before they go into effect so that you can begin tuning and mapping to new charge descriptors if needed, so that your services are all properly captured when they go into effect. You may have what's called policy or payer updates and alerts. This is essentially where your insurance company comes in and says, hey, we're changing how we're going to pay for this service or this charge capture. There will be a proposed change oftentimes with that. And as you review that, it says here most of the time it will align with the fiscal year. However, there will be times where an insurance company or a payer has to make an update or a change, and it will go into effect immediately because of reasons that they may be applying new changes in the world and so on. So now we make the connection here is how do we look at clinical coding with the reimbursement connection? So we saw already that there's a lot of the code sets that are used for charge capture and your CDM. As we look at these and how they're actually used in the revenue cycle, you want to keep in mind that the purpose of your code sets is to communicate information. So you're communicating what was done for a patient, why it was done, any complications, any specific details. Part of this is intended as a record of information about your patient. Part of it is intended for payment, while other parts of it are intended for data and research. All of that information goes into our data bank, and it's kept in our electronic health record and is pullable through aggregated data. But as we talked about reimbursement, we use those codes in order to identify those charges that we mentioned earlier. This allows us to say, hey, we did a service or we did a procedure, please give us payment. And it associates the actual service that was done for that payment. So we don't have to justify the payment. We've already told the provider or the payer, sorry, what the provider has done. And of course, just some background as to how our information is standardized. We do follow our code sets through Transmit Health Services under the HIPAA rule, which basically talks about fraud and abuse as well as privacy. With ICD-10 PCS or the PICS coding system, we can look at these in our textbook, and so I'll pause the video and pull that up for you here. Okay, so we can see here the HIPAA designated code sets, which we've already mentioned, but really just breaking it down to what is it. I love this table here because as we've talked about in coding classes or coding videos, if you've watched any of me talking about the difference between inpatient and outpatient, most offices think in terms of what's in or outpatient. However, I always point out is there is your physician or professional-based billing and your facility-based billing. And so you can see several of these different areas have the same code sets. And this is defined based off of the location and the type of service, not just the location. So you want to identify, of course, in outpatient setting, it's all the same. You're going to bill all of your diagnoses with ICD-10 which is the same as inpatient, by the way. And in outpatient, it doesn't change whether you're billing for the facility or the professional or physician charge. You'll still use the CPT or the services. However, in the inpatient setting, there's two different types of bills. You have your physician or professional base, which utilizes your CPT codes for your procedures and your ICD-10 codes for your diagnoses, while the facility or the hospital itself will bill the same diagnosis codes associated with ICD-10 PCS. Now, if you're wondering who releases those ICD-10 codes and splits them between CM and PCS. Yes, I made a fun joke here. The World Health Organization is responsible for those updates. It is important to point out that there is a new revision of the ICD series coming out soon. Initially, it was supposed to be starting in 2022, but with COVID and several of the delays, we have seen a delay, and it is expected that we will be using ICD-11 sometime in the next 2 to 5 years. In the US, that simply means that as we start to transfer over, we'll start to have training and more information as we go. The US has always been a little behind on adapting to the new coding system. So you can see this was actually referenced in 2020. And of course, before there were a lot of changes. If you're interested in finding out information on ICD-11, you can Google search this, and you can find information from the World Health Organization on ICD-11 here. So all I did was start a search for ICD-11. This is as of 2022, and it gives me some information on what is ICD-11 and what are common standards that I can find on this. So this is talking about when it's going to affect. ICD-11 is an online classification system similar to ICD-10 that is really just going to be utilized instead of ICD-10. So in some instances, there's information talking about us adopting it in 2022. However, as we know, in 2023, this has not yet gone into effect. What I would say to students who are learning about ICD-10, ICD-11 is in the revenue cycle setting, as soon as the print is made, it probably changes. But keeping up to date is the most important thing on this. You can follow information from the National Center for Health Statistics as well as from WHO, but really your organization will keep you up to date on all of this information. And as a new student trying to find a job in the healthcare field, keeping posted by following information from CMS as well as following WHO directly will help with that process. Now, talking about the ICD series, ICD is the International Classification of Diseases, and it does look at both disease diagnoses as well as procedures on the facility side, as we mentioned. ICD-10, which is our current version of the ICD series, is the 10th revision that went into effect in the US in 2015, but was in fact started about 5 years prior. ICD has updates every single year, so even though those revisions change, we still get updated information on everything that is done. Okay, and we went backwards. A little bit of updates on the ICD-10 CDM structure. In the ICD categories, this reads very much like a computer category. So everything is about what category, what subcategory, and what subcategories are affiliated with the charge description that we use. So you can see here an injury code to the neck, which uses code S10, then has several variations of subcategories based off of where within the neck and specifically what kind of injury is done. So as you can see, the final code here, S10.11XA, is built by breaking down the subcategories. If you've already taken medical coding, which this class does require, this should be a really good review of what an ICD-10 CM code looks like. With our PCS, our inpatient procedural codes, this is developed, this actually came out new in 2015 with the ICD-10 revision. This was very unique and used only by the US in reporting for inpatient procedures and utilizing for revenue management. Similar to the ICD-10 CM, we still have a category which is listed with 3 characters. However, we use tables in order to identify the PCS code. There's no decimal point. And breaking down the category first by the table, which is identified with those 3 characters, and then looking at each of the characters that follow after up to a 7th character. So each one has its own meaning. Even though ICD-10 also has a meaning to each code, PCS is really big on pushing the structure of building your code versus finding your code. Now, talking about revenue cycle management, as we look at the ICD-10 CM and PCS rules and guidelines, this is just giving us some of the information of where to find updates on each of these for maintenance or updates in your system, looking at guidelines, and where to find additional advice. So you've probably by now heard of some of these, like AHIMA or AHA, or the AHA Coding Clinic for ICD-10 CM and PCS, which are all publications that you can purchase as a medical coder or as a revenue management employee or administrator, depending on what actual vocation you're going to need it for. Subsequently, the HIT structure is broken into, as I mentioned earlier, 2 different levels, your CPT or your HIT levels. So your level 1 and level 2. Some history on that with your CPT. This actually started in 1966 by the AMA and then became part of the HIT in 1985. So we had a good 30 years or so, well, 20 years or so, that CPT was by itself before becoming one system adapted with the HIT in 1985. This can be used by any type of facility for inpatient or outpatient services, but it is specifically used for professional services. And so we have some examples of this here, where your CPT will be used. There's also category 3, which is going to include new technology codes and various alphanumeric codes that are used for reporting and tracking. Really, these are usually going to be used for your facility to report information that's being requested by the insurance or to report information for intensive purposes of getting the new code into the main system, which is your category 1. So your category 1 is going to be associated with payment systems, while your categories 2 and 3 may or may not have payment associated with them. And you can see some examples here, like tobacco use was assessed. That's really just kind of a data information, while breath test for a heart transplant rejection is an actual procedure information that we're hoping to get through use of this code, enough information and data collected so that it can not only be considered for payment, but also considered as a normal new procedure that is being done. Of course, the guidelines are going to be released by the AMA, and this is going to be done each year in October with the new code sets. HIT, however, are a little bit different. As mentioned, they were created in the 80s, and it is developed and maintained by CMS. You'll identify a HIT code because, as you can see here, they're all alphanumeric. So they always start with a letter in the beginning, followed by several numbers. Whereas if we go backwards a little, our CPT codes are only numeric codes. Our category 2 codes are and category 3 are both alphanumeric, but have a letter at the end of the code instead of in the beginning, like the HIT here does. Right now, our HIT are really just used for reporting what kind of medications patients are receiving, what kind of equipment that they may have received, like crutches and supplies, as well as things like ambulance services and specific services done by Medicare patients. These might be, for example, your G codes, a hospital observation service, which has its own service in the CPT book, but is very specific for Medicare patients here. Now, there's information for advice that you can get from the American Hospital Association at AHA. Oftentimes, this information can be collected in a lot of ways. For users with the 3M encoder, for example, a lot of the information on a specific CPT code can be found just by pulling up the CPT code and looking at resource and guidance. Additional information can be purchased. So depending on the different area of coding that your office does, you can pick up various coding clinic books and publications that are specific to your area and field. All brought together, finally we look at the coding process. For facility coding, this looks at both the diagnoses and procedures of the facility claim, which is called an 8371. There's soft coding, which basically means that professional goes in and looks at the services and says specifically what it looks like for the codes based off of the charge description and what's in their system in their CDM. However, a coding professional, which is usually an individual who has credentials as a medical coder, will go in and look at those in more detail. And we do have an example here in our textbook, which I'll pull up here. So in our textbook, we can see example 10.2, which we'll read together. A large metropolitan hospital with a coding team would consist of an inpatient coding team and an outpatient coding team. The inpatient coding team will have coding professionals excelling in ICD-10 and ICD-10 while the team may be divided further even by clinical areas. For example, there may be one or more professionals designated to code complex cardiovascular procedures such as heart transplants, implementation of heart assist systems, and coronary artery bypass procedures, also known as a CABG. An additional team may have coding professionals designated to code and deliver births. While an uncomplicated birth may be routine and familiar to most coders, complex pregnancies and births are difficult to code and may require coding professionals with extensive experience. This is especially true in medical groups. I've worked with a couple of different areas and I've seen it myself where different providers' specialties are given to different coders. As coders, they may have 2 or 3 specialties specific to their knowledge and training. Now, as we mentioned, there is different directions that you can have. So on the professional coding, as opposed to the facility coding we looked at a moment ago, you have diagnoses and procedure codes for professional claims and 837P. So this is meaning professional. These coders or individuals should be well versed in your CM coding guidelines and understand very clearly how to link a diagnosis code. When we talk about linking, we simply say that in the actual system, you're going to say, what is the procedure code in your charge capture? And what is the diagnosis code that was done for? And when we link it, we tell the diagnosis code and the procedure code that this is done for this diagnosis reason. And there may be multiple reasons that it's done for. And so in those cases, linkage would mean that the coder would select reason number 1 as the first diagnosis, all the way up to, I believe, 12 or 16 reasons, depending on the system. Most simply go with 4. A single path coding is one where someone is listing codes for both the facility and the professional services. Oftentimes, this is something where the facility has linked the charge capture to identify both sets of codes from PCS and CPT, so that when a coder or an individual who is selecting those charges goes in, they can select the correct information that will then provide the coding for both sides. This can be very beneficial when those in fact do match correctly. Finally, here we have a patient connection. We have Nick, who's an analyst at Memorial Hospital and who's reviewing the charge capture data for knee arthroplasty surgeries. We're going to look finally at our textbook to look at this with Nick. But we're going to review. Let me go ahead and pull that up now. So here I have our patient connection where Nick is taking the information from analyzing for a patient named Malachi. He's really looking at the length of stay for the patient in the office, or in the facility, I should say, and determining exactly what's going on with this patient to make sure that we've collected all of their charges. We can see here on patient care day 1 that there were several charge types and documentations in the record for each. However, on the claim, one of these was missing. And so Nick did go ahead and mark this so that he could summarize the information in reviewing with his providers. When he looked at day 2, there was again several items that were being captured, and yet again there was a respiratory therapy that was not captured in our billing. So we can see the documentation was found for each of these items that were done, but not all of the coding. On day 3, Nick also noticed that, again, respiratory therapy is missing. As we continue on, we see a common trend. And if you haven't guessed it yet, Nick should probably talk to the respiratory therapy department to determine exactly what's happening and why those charges weren't listed. Additional areas like the lab test that was missed here. And on day 1, when the patient Malachi was moved to the recovery room, might be investigated as well to ensure that something wasn't missed. When we go back to our summary, we can see here that after reviewing 50 patient records, Nick actually found several office records that had the same issues. So what do we do when we find something like this? In the middle process of revenue cycle management, it's our job to look at the root causes for these and try to fix it. So Nick's going to meet with the director of respiratory therapy and see what they can find. He's also going to meet with the laboratory director and identify for the missing culture charges to make sure something wasn't missing from the system. And then finally, he'll meet with the recovery room nurse to see if anything was missing in that area as well. You can see that there's a lot of missed revenue from them. Sometimes this could be the difference of a specific individual's pay as well. That's all I have for you today. So make sure that as you're reviewing for revenue cycle management, think of the different areas that you might benefit or find enjoyment in working with the different threads of what makes the circle loom of revenue cycle. Until next time.